Hey, I'm Dr. Dino Pappas. I've had a couple cases recently of lateral epicondylalgia. That's pain here in the lateral forearm, commonly called tennis elbow. Unfortunately, some of these cases have been misdiagnosed. So this is for the patients out there and also the providers, how to sift through the layers to figure out if this is truly an elbow problem or if the problem is coming from somewhere else. So let's rewind here. The diagnosis of tennis elbow is given when they have pain right here on the outside part, this part of the elbow. This is called the lateral epicondyle, and this is where the muscles that extend, bring the wrist back, have their attachment on here. And the theory is these muscles pull on the attachment and cause pain and discomfort on that attachment side. But unfortunately, there are several other diagnoses and several other conditions that mimic this problem. The first of which, the cervical spine. The neck can actually refer pain down into the elbow. So the question is, how do you sift through or peel back those layers? Well, one thing that's kind of helped me out sift through those layers is the Mckenzie Method and repeated motion testing. Namely, if you put the neck in certain positions, does it relieve symptoms at the elbow? Does it make symptoms move back towards the source, back towards the neck? Does it improve pain-free motion, strength of the wrist and elbow, and then range of motion of the neck? The most common ones that we find is cervical retraction, bringing the chin back, retraction and extension, and then same side, ipsilateral, same side. If it's right-sided lateral flexion, and right-sided rotation. And if you do that, and it starts to move symptoms back towards the neck, decrease pain distally, and improve tests of the wrist, then there's a good chance that this is more of a cervical referral than the actual tennis elbow. The second thing, is there an elbow derangement? Derangement just means something inside the elbow that's reducing motion of the elbow. The most common motion loss in the elbow is elbow extension, going into this position, locking the elbow out here, or locking the elbow out in this position. Add in sometimes a rotational component or a lateral to medial or medial to lateral glide component, and extension is the most common area. So testing the elbow over and over and over again into extension most of the time and seeing if the symptoms improve at the elbow. The third thing, a tennis elbow can be a contractile dysfunction. What does that mean? Resisted contraction provokes the pain here at the elbow, or we call it the middle finger extension test. Holding this up against resistance, it provokes pain here. That's more of the contractile. And a contractile problem basically means that we need to strength train it. First with isometrics, load it in a mostly non-painful position, holding it for seconds, 10-15 seconds, repeating that 4 to 6 reps, progressing the resistance, and then getting into the eccentrics where you're controlling that down to get the tendon to be bigger, faster, stronger, and more adaptable at the elbow. Again, so that's another way that all roads lead to Rome to get into tennis elbow is the tendon itself needs to be strengthened more than the other tissues. The last major issue that we find is called radial neuropathy. And what do I mean by that? Running around this area in the elbow is the radial nerve. The radial nerve exits the brachial plexus, runs down the outside part of the arm. Stimulation or entrapment in the elbow, namely, can be called radial tunnel syndrome or supinator syndrome, depending on the location. So 2 different locations at the elbow can produce this condition. How to test for it? Thumb, index finger. Hold your thumb and index finger up, press it down. If it's pain right here on the elbow, it's more commonly associated with this radial neuropathy than it is true lateral epicondylitis. Also, testing the supinator muscle, having them resist supination, which tenses the supinator. Again, if that triggers pain at the elbow, it's more likely that it's radial neuropathy more than the actual tennis elbow contractile dysfunction. Ways to treat that would be to go into radial mobilization, nerve mobilization, or doing some of our myofascial release and manual therapies in and around the elbow to free up the nerve to slide and glide properly. So consider that when you're diagnosing, assessing, and treating. Multiple different things can lead to pain at the lateral elbow, and it's up to you to figure out how to sift through these diagnostic triage. I'm Dr. Dino Pappas. Thank you.